a reminder as kind of each of us think about the immigrant experience and story is that it might have been a recent experience for some of us here, but likely at some point in our family's history, they went on these fairly epic sounding journeys, as you'll hear, and the resilience that comes with having endured all that they went through. Here's my selected CV. You'll see the name Sidhu is on there a lot. I work closely with Dr. Sean Sidhu, who many of you may know from, who was at the University of New Mexico, is currently at University of California, San Diego. So want to give credit that many of the ideas and framings I'll be using today come from him and our work together. So here are learning objectives for today. So I'm hoping that by the end of the presentation, you all will feel like you will be able to kind of talk about different pathways of immigration, and that you'll be able to talk about how different perimigration stressors, so stressors that happen before, during, after migration, affect immigrant families' access to effective health care and community resources, as well as summarize the need for trauma-informed and culturally adapted care for immigrant families. But I also would love to hear from you all if there are, maybe you saw the title and you thought, oh, I have certain questions or thoughts about this, working with this population. If anyone has any kind of other objectives that they were hoping to learn today, please feel free to voice them now. You can unmute or type it into the chat. But otherwise, we'll kind of dive right into these. So working with our first objective, pathways to immigration. So immigrants are a pretty heterogeneous group, as you can imagine. We talk about, immigrants, and there are similarities, but also many differences. So what country of origin are folks coming from? What did their migration journey look like? Once they arrive, what are the different avenues for them towards citizenship or to work? We won't dive into all the legal qualifications today, and immigration law can be very complex, so you can thank me later that we won't be getting into all of the nitty-gritty. But what we'll be talking about today is just to give you a sense so that when you are working with a client who's a migrant, you have a sense of what they may or may not have gone through, how they may be similar or dissimilar to other folks that you have worked with. And there are many pathways to immigration. And today we're going to be focusing on families who are fleeing torture and persecution. So this is going to be refugees, asylum seekers, and the undocumented. So while those populations may be our focus today, many of the principles can be applied to immigrants who arrived via various routes. This could also include people who were adopted internationally as children, people who are first generation U.S. citizens, as well as those who are now currently U.S. citizens. So first off, who are immigrants? Well, in my day-to-day, and I know many folks here work in healthcare as well, often immigrants that I experience are my attendings, my co-residents, medical students that I work with. Many are immigrants, many are even refugees. Immigrants are actually overrepresented in healthcare. So whereas the national US population, 17% of people living in the US are immigrants, about 28% of doctors are immigrants and 36% of home healthcare workers. And immigrant doctors are more likely to work in rural underserved areas than American-born doctors. So many immigrants have been on the front line during the pandemic over the last year. So who are immigrants? Immigrants are us. They're our colleagues, our patients. In addition to doing work like healthcare, helping us take care of our health, our loved ones' health, immigrants are often found doing work that puts roofs over our head, that grows and cooks our own food, that takes care of our children. So it can often be fairly intimate work. And how much do we know about these neighbors? Do we know that whether documented or not, they're contributing millions to the New Mexican taxes, billions to the New Mexican economy? Do we know that they're entrepreneurs, that that they have endured what they've endured, the journeys they've gone through, the losses they might have had along the way, the actions they might have taken that they weren't proud of, the systemic injustices they're enduring, their hopes, their dreams? We'll talk about some of these today. But for now, here's some information about immigrants in New Mexico. So about 1 in 10 New Mexicans are immigrants. 41% of immigrants in New Mexico are citizens, and 29% are undocumented. About 72% of immigrants living in New New Mexico come from Mexico, and then you see a smattering of other relatively highly represented countries. About 1 in 10 New Mexicans who were born in the US have at least one parent who is an immigrant. And 1 in 11 New Mexican children live with at least one undocumented family member. So that brings us to just short, and then there's about just short of 11,000 children living in New Mexico who were born in another country. So with these numbers, you can see that depending on kind of the diversity and number of patients that you're seeing per day, it's very likely that you're seeing a couple folks who are immigrants or who have a parent who is an immigrant in your office each day. And if you work with children, there's a high chance that this child lives with a family member who is undocumented. And we'll talk about, how fear of deportation can affect access to healthcare here in a while. And because this is a webinar looking at rural New Mexico, which much of the state is, want to know about the immigrant presence in rural New Mexico. So many immigrants, say refugees, are resettled in urban areas, but there's also likely concentrations in the borderlands in southern New Mexico. And then, as Dr. Kreichman pointed out to me, many Texans may see New Mexico as a more immigrant family state, and so may come over to New Mexico for healthcare. So we might see more rural Texans, say, coming over to eastern New Mexico for healthcare. Many immigrants, as you see in this picture, work in agricultural settings, so may live in rural areas. And then, of course, ICE detention centers are often found in rural areas. So in New Mexico, we have 3. That's Otero County, Torrance County, and Cibola County. And those are located in rural areas as well. And here is a good overview slide. It's fairly clear if you start to look at it, but also you're going, oh my gosh, if this is clear, how complex can it actually be? So a good overview slide about some different ways that people who are fleeing torture and persecution arrive in the United States. So today we're going to be focusing on the first, third, and fourth arrows, so the A, C, and D arrows. So first, we'll just kind of talk briefly, and we'll go into these a little bit more in a moment, about refugees. So refugees flee persecution, flee danger, and before they arrive in the US, the UN or the US designates them as refugees, so they have a certain status, and the US facilitates their resettlement into the United States, the US Department of State, working with the Office of Refugee Resettlement, ORR. And then they work with local agencies, so New Mexico, that's Lutheran Family Services, to resettle the refugees. So they flee before they arrive in the US. At the border, you can see they get refugee status, and then they're helped to resettle. This is quite different, and you can see the C and D arrows. So C is kind of if A is the classic refugee, C is the classic asylum seeker. So there is torture, persecution, danger in their community, and they flee. They arrive at the border, they say, I'm afraid for my life, please let me in. The US lets them in, and an interview is done with Customs and Border Patrol called the credible fear interview. And if it's determined that this person has credible fear, then they await their case, sometimes in detention, sometimes in the community, and they have a hearing with a judge that determines whether they will be granted asylum or not. If not, they're deported. If so, then they're allowed to stay in the United States, and there's different pathways to citizenship. But even as soon as arriving at the border, someone might say, well, I'm here because it's better work opportunities, and Customs and Border Patrol might say, well, that's not sufficient, and they may be deported. Or they might say, well, I was sex trafficked by this gang, and Customs Border Patrol might say, well, what's the evidence? And a person might not have any. And so more and more the burden is on asylum seekers to prove that they've suffered this persecution. And we'll talk more about this in a bit. So that's C. And then D is where someone is fleeing persecution and they arrive in the United States. Now, not as a refugee, and they don't present for asylum at the border, but maybe they come over on a student visa or a tourist visa and then overstay the visa, or they come over without documentation. And then at some point they interact with ICE, maybe it's a workplace raid or something. And then they are, maybe detained until they're going to be deported. And then they can defensively, is the term, apply for asylum, where they say, well, look, I was suffering from persecution. I can't be back there, otherwise I and my family will suffer immense harm. And so then someone can apply for a defensive asylum application, and then they have a similar hearing as to someone who's applying more affirmatively. And that will decide whether they can remain within the United States, or whether they will be deported back to their country of origin. So we'll talk a little bit more about refugees specifically. So as mentioned, a refugee is fleeing dangerous areas and situations that their government is perpetuating, causing, or is unable to make a significant difference regarding. So this can be civil war, this can be human rights abuses as perpetuated by the government, this can be widespread community violence that the government or police is unable to control, like gang violence. This could also potentially be natural disasters with climate migrants, where if, say, a hurricane devastates a community, a country even, and the government is unable to kind of sufficiently provide safety for its citizens, then that might cause someone to become a refugee. So a refugee leaves their country of origin, crosses a border, and they become eligible for protection by the UN or other organizations, and they can be granted refugee status. And once someone has refugee status, they have special protections. And so why I chose these pictures, you can see this like blue logo. This is the UN High Commission of Refugees. Certainly on the picture on the left, I'm pretty sure it's on the right as well, but there's some kind of logo on the tarps. Regardless though, this is indicating that folks who are refugees have resources given to them when they're in between countries, right? When they've left their homes, but they're not at a place where they can permanently resettle. So they are given, the UN will come in, will give tarps and tents. You can see these jugs of potentially water. On the right, you can see maybe even more stable or more like less temporary housing structures, these kind of little houses. So there's more infrastructure and resources provided to refugees. And you'll see this differs from asylum seekers in a moment. And so the goal with refugees is that they can either safely return home or integrate into the host community, or resettle in a third country that accepts them. So often this is Western nations like the US, Australia, Germany. And while that's the goal, that does not always happen, right? Unfortunately, many people may stay in refugee camps a long time, even across generations. And we don't have time to go into it today, but it gets into some really interesting like questions of identity, right? Someone might say, well, I'm Syrian, but they haven't been to Syria in years. Their children have all been born outside of Syria. And then for a child whose one of their primary tasks is already identity formation, what does that mean as they're trying to figure out who they are in the world, who their family is in the world? But typically the idea is that refugees will be resettled or things will become safe at home and they can return. Here's a couple New Mexico organizations that work with refugees. So the Department of Health has a refugee health program that helps with physical and mental health of refugees. And then there's Catholic Charities. So they provide educational leadership resources to refugees, and they worked with 297 refugees last year, so just about 300. So if you work with refugees, these may be organizations you could consider liaisoning with or referring to. And then this picture is from a program called the Refugee Wellbeing Project that's out of University of New Mexico. This was started by Jessica Goodkind, and I understand Dr. Brian Isaacson is also very involved. And so what this program does is it pairs newly arrived refugees with UNM undergraduate students. And the idea is that there is cultural exchange, community building, an emphasis on promoting refugee wellness and access to resources, as well as education for the students. So here are some of those folks within the program, kind of from both parties, students and refugees. Refugees in New Mexico are often from Afghanistan, Iraq, and the Great Lakes region of Africa. Just a picture of them with our mountains enjoying New Mexico sunshine. So that's refugees. Now we're just going to talk briefly about asylum seekers. So where refugees have legal protection before they arrive in the United States or whichever country they're seeking to go to, asylum seekers are just that. They are in the process of applying for asylum. They are seeking legal protection. So they flee persecution, head to a border, usually, the border of a country that seems like it's going to be the safest one for them, or the nearest one that seems safe. And there is no guarantee when people who leave their homes without refugee status, there's no guarantee that they are going to be resettled anywhere or given resources anywhere. In fact, many ultimately are deported back to their country of origin where they reported this persecution occurred. So we don't know a whole lot about outcomes in this population, but there was a study done a few years ago by San Diego State University that tracked folks who were seeking asylum. Their claim was denied, and they were deported back to the Northern Triangle in Central America. So this is Honduras, El Salvador, and Guatemala. Honduras is currently the murder capital of the world. And so they found that 83 of these asylum seekers were murdered in the year following their deportation, which would seem to suggest there's likely there was some correlation with the persecution they were reporting and what they endured, but clearly it's unclear. And that doesn't account for, folks who were kidnapped, raped, trafficked, or were killed outside of that year period. So all of that is to say is it's this fairly precarious choice that asylum seekers are making. But when you see, as we'll talk about with perimigration stressors, what they're fleeing, it seems, potentially like the obvious choice. So asylum seekers flee and show up at a border. And as you can see in this picture, which I think is like really illustrative in a few different ways, is they're greeted with border patrol agents and a whole lot of paperwork and potentially detention. So in this picture, I feel like it's nice because you see like this adult at the back who's like looking really concerned, looking at this stack of manila envelopes in the Custom and Border Patrol agents' hands. You see the Custom Border Patrol agents with their badges. Very visible. This is clear that this is a legal process as well as a humanitarian one. And then you see this adult in the gray who's looking at all the paperwork. And then the child at the front who is like looking ahead, maybe a little bit of a smile. And that is a crucial part of any immigration story, especially for asylum seekers, is some hope that what's on the other side of this bridge or this border is going to be better than what's left behind. It's a gamble, but sometimes the only choice. So asylum is defined differently in different countries. And so in the States, there's this idea of persecution. So we talked about that a little bit, right? That persecution, it's different than if, say, your neighbor was harassing you, or you were a victim of domestic violence, where you could go to the police or the justice system and potentially get protection. With persecution, the government or the police is either the one causing the harassment or the violence, or they can't stop it. So where we see this a lot with folks from Central America is that there's gangs, running amok, running cities, running countries, per reports of asylum seekers and advocates in the country. And so even if someone was being harassed by a gang and they went to a police and there's a police force, perhaps the police is working with the gang, and then the family would be punished for bringing up their concerns. So persecution is a specific legal term, and it's getting at that idea that either the government is doing it or they're allowing it to happen. And then when you apply for asylum, it has to be that you're running from persecution based on what are called protected grounds. So it's one of these 5 groups: race, religion, nationality, political group, and social group. So this gets tricky, right? If someone is like fleeing a natural disaster, that wouldn't necessarily fall into asylum, but there's other forms of humanitarian relief that would be available. But asylum has to be persecution based on these grounds. And then just a brief note about, so right, traditionally, asylum is you present at the border and say, I need asylum, I'm afraid for my life. This is kind of the way it's been since World War II, when a lot of the refugee and asylum laws were first defined and established. But in the last few years, you may have heard of this Remain in Mexico program, or migrant protection protocols. So instead of people, the United States, saying, oh my gosh, you're fleeing from persecution and torture, come on in while we assess the veracity of your claims, instead, the United States has been saying, okay, we'll look into your case, but you cannot be in the United States while that is done. And so what happens is that these camps have sprung up across the border of US and Mexico. It's specifically for people coming through Mexico, the southern border of the United States. And as you can see, these tents look quite different than the tents we saw on the refugee slide. These are donated by nonprofits. They're tents. There's a whole lack of infrastructure, and you can imagine how that's been during the pandemic. And so it's like refugee camps, but without the resources. Now with the new administration, so this is Matamoros, these have largely emptied out in the last month or so. For folks who had asylum cases pending, they have been allowed to come in as the law had previously been defined. But there are new folks coming up. So there might be some regeneration of the camps. It's kind of unclear at this time. But just to show you, like, well, I thought asylum seekers come to the border and get let in. There's a lot of overlap and things are unclear. And it depends on kind of hotly changing immigration policy. And then here's just a kind of final slide in this section about immigrant children. So, there's asylees, asylum seekers, refugees who, again, are born elsewhere, fleeing torture and persecution, and then are either seeking asylum, or granted refugee status. And this is different than dreamers. These are folks who often were brought over, often as very young children, by their parents. They were born elsewhere, often in Mexico, Central America, came over with their parents, and they might have grown up stateside, and an American identity may be a significant part of how they understand themselves, but they did not come through a documented process like being a refugee or an asylum, and they may be living with undocumented family members. And you've probably heard about DACA and Dreamers, and that's not kind of the focus of our presentation today, but just to give you a sense, if you have a child and they say, oh, I was born somewhere else, or my mom was from somewhere else, you might need to tease out kind of what category they belong to, because that could kind of give you ideas about what they, like I said, have or have not been through. So now we're going to move into perimigration stressors. So again, these are stressors or traumas that occurred prior to migration, during, and after. And because we have kind of a sense of like what these different immigration pathways look like, and now what can those journeys look like for kind of individual folks. So first, looking at pre-migration trauma. So these are like the incidences that propelled people to leave, right, to flee their homes. So this is a quote from a report from Physicians for Human Rights, and the first bolded section. So this was a report of parents who've been separated from their children, which we'll talk more about in a bit. But this is what the parents had said happened to them: that they were a victim of gang activity, death threats, physical violence, relatives killed, extortion, sexual assault, robbery. And the second bolded area is what their children had been through: gangs, drugged, kidnapped, poisoned, threatened children, threats of death, violence, or kidnapping. Asylum seekers that I have worked with has been a whole host of pre-migration trauma, everything from their homes being infiltrated and massacred, witnessing their loved ones being hurt or even killed, people fleeing from civil war, or maybe even for years, they were kind of fleeing across the country, trying to find safe havens. Kidnapping, sex trafficking. These are essentially like the worst things that humans can do to one another, is what many of these folks have endured. So often they've had these horrific traumas, and at some point they make the remarkable decision to leave their homes behind, everything they've known, potentially, maybe the places where they have been happiest, where they've had their memories, but home chases them out. So here's on the left, we have migration. So now we're talking about migration traumas, like they're leaving, and now what does that look like? So it looks different depending on what part of the world we're in. On the left, we see this is a boat crossing the Mediterranean. You see how cramped it is. We hear about the regular, unfortunately, capsizings and drownings that occur on this journey. And then on the right is a little closer to home. So each red dot is where human remains were found. There's a policy in the late 90s called Prevention Through Deterrence that forced migrants crossing through the Sonoran Desert to, instead of presenting at urban ports of entry, to go through less populated, more dangerous areas of desert and mountains. And the thought was, hopefully this will keep people from presenting at the border if we make it a more dangerous journey, which that did not seem to be the case. But here we kind of see the results of that. And these were the remains that were found, right? There have been some studies done recently with pigs that found that, so it used to be thought that human decomposition in the desert was about like 6 to 9 months. What we have now found is it's closer to about 9 days. And if the body is covered in rocks, as is often done to protect from animals, is the idea, right? You're traveling with a group and someone passes away and you try to protect them, their remains. But unfortunately, the rocks in the desert can make the body smell certain ways and attract even more animals. So if these are just the remains that we found, and for those bodies that were under rocks, they decompose in about 24 hours. So how many more times of the remains would there be? And it's estimated that it's probably double to 10 times what we're seeing here. So all really arduous things to consider that someone going through. And so it's to help remind us that the people we're seeing are the survivors. So maybe they've seen others succumb to traumas like this, but also they are the ones who made it through. And then they arrive stateside or whichever country they're going to, and often more stressors or traumas await. So what we have listed here are some of the more like dramatic, traumatic events, but we also know there's more chronic, more insidious stressors that occur too, right? So just the unfamiliarity of working with a new system of government, healthcare system, school system, a new language, like not knowing how to work appliances. Any of us who have traveled abroad have a sense, like on a much smaller scale, what these stressors are like. But imagine, being immersed in it and you're trying to find your way around this new society. And so we know there's often this building block effect with these perimigration stressors, right? So perhaps someone had the coping skills to make it through their sexual assault and their kidnapping and their migration journey. And it's not until they're maybe stateside and they are overcome with the stressors of trying to navigate this new system, grieving people they lost along the way, maybe experiencing discrimination, that maybe that's when they decompensate and end up in your office or in your emergency department. And it's good to recognize the strength and resilience a patient like this would have shown to have made it through all they have in their life, even if when you're seeing them is when they've been finally overcome by the immense stressors that they've endured. So one of those stressors that can happen kind of at the end of the migration journey is family separation. This is talked about in the news a lot. And so this quote, so this comes after, let me show you. So I want to draw your attention to the last line on this. So this is from the Physicians for Human Rights report. So this says, parents were confident the journey to the United States would result in protection for their children. And the next line is, when they arrived in the United States, however, parents reported that immigration authorities forcibly removed children from their parents' arms, removed parents while their children slept, or simply disappeared the children while their parents were in courtrooms or receiving medical care. So unsurprisingly, this is what we're finding as more and more data about this population comes out, is it's had significant impacts on both children and parents. This is a critical disruption in attachment for a child, and we don't know a whole lot about the long-term effects, how this generation of children who are affected by family separation, what those outcomes will look like. But here's what we know about the short term. So this is from a study that a paper Dr. Sidhu and I wrote that'll be coming out in the next couple months. So this slide is about asylum seekers specifically. So this is people who present at the border, and this is like the dramatic, like child taken from the arms, parents not being aware that this was going to happen potentially. And so we see two studies, you can see kind of in the red there, two different groups of parents and children. And you see there was pretty widespread psychiatric symptoms or even diagnoses that both parents and children seem to display. With the children, you see in the turquoise in the first study, a lot of developmental regression with things like enuresis, not able to sleep independently when they were before. And with the second study regarding the specifically interviewed mothers who were separated from their children about how their children were doing, the second study indicated something that was disheartening was that a couple things. One, that the problems endured after reunification. And second, that short-term separation seemed to be as significant as those who were separated for longer periods of time. With refugees, they experience family separation in a different way. So it's not necessarily like imposed by government officials at the border, but it can be imposed by policies of the countries in which they're going to resettle in. So for example, let's say you're migrating with your children and your niece that you care for. Well, the country you may be going to may say, well, you can't bring your niece in here. And so you have to make the decision, like, do we stay amongst civil war or do we leave them behind? And so sometimes it's policy, but sometimes it's like forced choice by circumstance, where maybe you're going to be traveling a route that your ailing parent won't be able to travel, and so you have to leave them behind. And so unsurprisingly, this separation can serve as a barrier to functional resettlement in the refugee population. So many psychiatric symptoms, as you can see, depression, anxiety, PTSD, often they have gone through immense trauma and now they're being separated from their most intimate emotional supports in their life. So you can just see how these things can kind of build. But a positive thing that's been found, there's more studies about this population over several years, is something that the studies emphasize again and again, is that familial reunification, if families are able to reunite in the new country where the refugees are being resettled, this seems to focus or function as a positive accelerator of integration. So you can see, if you're just so torn up about the safety of your parent, are they okay over there? I'm so sad that I left them behind. I feel guilt, and now you're reunited. That allow you to function better. Here's moving in from family separation to detention as a post-migration stressor. So this is from a study or a paper written by Dr. Sidhu and Dr. Rahul Vasareddy, who some of you might know, who's a UNM resident as well, looking at the rates of mental illness across 3 studies of children in blue and their parents. So pretty astronomical rates of depression, anxiety, unfortunately suicidality really high as well. And again, you see in kids these conduct problems and these developmental regression problems emerge. Here's a little bit of what detention looks like. Again, thinking about the pandemic, not necessarily the sanitary places. And this is a picture of people using these blankets. We'll call them space blankets. Often migrants will refer to the detention centers as ice boxes, which is a reference to the agency ICE, but also just how cold it is in these centers. It's kept very cold. I've had people tell me they thought that they were going to die or their children were going to freeze to death because of how cold it was in there. And this is one of New Mexico's detention centers, Otero County Detention Facility. So then, let's say someone makes it to the United States, maybe they've endured family separation or detention, or maybe not, but then there can be this fear of deportation. So this is for people who are undocumented, but also for asylum seekers, right, who their case is pending. I mean, these cases can take years. I had a child once who was 11 and had been in the United States since he was 6. So largely grown up in the United States in his later childhood, and they were still waiting for their case to happen. So there's this fear of deportation. And as you can see here, parental deportation linked to future emotional behavioral problems in children, substance use, unemployment, interpersonal difficulties with family members. So this can really significantly affect families and how they engage. You can see then with healthcare and other community resources, if they are equating, say, healthcare authorities with immigration authorities, they may not be accessing all the care and resources that they could. And just some images of what deportation can look and feel like for these families. And so what we know from studies as well is that fear of deportation affects parents, but also their children, like we saw on the previous slide. So problems with emotional adjustment, to support their children, their relationship with their children. And then this final bullet point, that the stress of being so worried about forced to go back to the place where they were persecuted seems to result in a parenting style that's harsher and less warm, likely impacting emotional development of children. And so now we're going to move into kind of to wrap up today. Now we're acquainted with these pathways to immigration and these perimigration stressors, what the journey can look like. How do we help care for the mental health of these populations? So we'll look at an overview slide, and then we'll kind of move from the micro, like patient interaction, to the macro, more systemic issues. So first off, this is from one study a few years ago out of Asylum Seeker Clinic in New York City with Mount Sinai. So here's some barriers to care. So internal, so like within the asylum seekers themselves, you see mental illness, which is a really interesting one because many of the asylum seekers interviewed in the study, they interviewed asylum seekers and providers. Asylum seekers did not think mental illness was a significant problem. For providers, they felt like it was a significant problem, that they felt like the asylum seekers were suffering from a lot of shame and stigma about what had occurred to them before they migrated, their pre-migration trauma, and about the mental health sequelae of those traumas, that they didn't want to discuss how feeling sad or overwhelmed was affecting their functionality or things like that. And so just looking at these barriers, of course, many of them are interrelated, right? A person may have mistrust because the system doesn't reliably provide them with culturally competent providers or interpreters who speak their language. They may perceive discrimination because they have been discriminated against. So they interplay, and it's fairly complex. we'll talk kind of more about the structural issues in a bit, and we've talked about assimilation with the difficulty adjusting to a new culture. So again, kind of moving into interacting with patients. So language is critical, right? Very important to have medical interpreters or trained interpreters. You know, we don't want to rely on children or family members to translate for us. Some studies suggest that therapy actually goes best. You can see here, twice as effective if the client gets to speak in their own native language. And this makes sense, right? These are our native language is the language that we dream in, that we formed our identity among. And so when engaging in the therapeutic process, which is often fairly intimate and emotional, you can imagine having access to your native tongue would be most beneficial. What's interesting is there's some studies that suggest that it's best if the therapist also speaks in their native language and an interpreter is used. And of course, what would be fantastic is having bicultural and bilingual mental health providers. And some of the folks on this call may fit that category, because I know New Mexico is blessed with many such providers. But we know from many studies that patients and clients prefer having someone who is similar to them culturally, racially, ethnically. So if you can, using an interpreter is critical. And then even better would be thinking about using culturally adapted interventions with patients and clients. This is just something to think about for all of our patients and clients, right? It's like, what do they think is causing the problems? Do they think there's a problem? And what would help to solve the problem? This is also just a way to begin to explore a patient's spirituality, religion, cosmology, how they understand what forces affect the world, affect their own well-being. And it's good too to assess like how much they know like about psychobabble and psychoeducation, because say an immigrant who's Gen Z may be very familiar with trauma and its effects. It's a much more a part of youth culture these days, versus someone who's older might not be familiar, even if they maybe immigrated very young and grew up in the United States, but now they're 65 or so. So just good to get a sense of what are the underlying kind of narratives that people have about any of their symptoms. And then when we're working with folks, we want to keep this idea in mind of, and this is pulling from the recovery model, Eric Fromm, Kai Cheng, these physiologic understandings of trauma is like what is meaningful for the patient in their healing, in their recovery, and their functionality. We want to look at dysfunction broadly, maybe help them frame it as something that helped them get through really difficult times, or maybe even being a natural reaction to a system there and that's hostile. I mean, if they're having trouble concentrating and sleeping and having these kind of physiologic reactions to trauma, we don't want to gaslight them or reframe it in a way so that the problem all falls on them when there may be systemic problems at play that are affecting their own mental health and thriving. So this is a really interesting topic, but the kind of takeaway is, how do we help, just like with anyone, how do we help everyone understand themselves fully, and things that are dysfunctional, what does that really mean, and what are we looking for with recovery or healing? And then, we've gone over these perimigration stressors, so it's good to factor these into our assessments when working with these patients. Being interested in family dynamics, what has the family gone through? How has that affected the family's roles, how they see themselves in the world, and also what stressors continue. Because, in some ways, the pre-migration stressors are so dramatic, right, that it's easier for folks to what's the word I want, like ascribe their current suffering to, well, of course I feel this way, I was sex trafficked, which is very possible that might be causing someone's current depression, absolutely, but also good not to kind of wave away current stressors that are going on that might be perpetuating their trauma or their stress. And we certainly want to emphasize resilience. Like I said, these are incredibly resilient populations often. And as providers, we have to be aware about secondary trauma and secondary burnout when working with a population that has such a high trauma burden. But also, I find a reason working with this population is so rewarding is that they're some of the most resilient people you'll ever meet. So if we can emphasize that, what they've been through, then it's kind of drawing from supportive psychotherapy, it's going to help them feel the strength that they certainly have demonstrated. And then of course, this is a lotus flower, which is a flower that grows up through the mud. And then kind of wrapping up, moving from the micro to more kind of systems level care. These are, approaches to clinical care that we want to keep in mind. So when working with these populations, often are from more traditional or collectivist societies rather than individualistic societies, we find more in the States. So having things be more family-centered, like if you are ever consulted to help build a physical space for immigrant communities, please advocate for larger exam rooms because often family is more involved in healthcare decisions than they are in kind of typical Western culture that we see. We certainly want to keep, and this could be a whole lecture in itself, right, trauma-informed care in mind when working with this population, thinking about how that reverberates throughout the clinic itself with staff as well as providers. And we want to make the care culturally sensitive, as we mentioned, that there's better outcomes we found when interventions are adapted to specific minority groups rather than just like, minority groups broadly. And then there's this really important question about immigration status, right? So if there's this fear of deportation and healthcare facilities are asking about immigration status or for social security number, this can make immigrant families feel unwelcome. And so they may avoid getting healthcare, even for their children who maybe have been born stateside, because they might fear that it would put them at risk of being deported, and they might fear a reoccurrence of the persecution or the conditions that they had endured before. And so, with this population, we just want to be aware of that as a note. You can note immigration status in your notes, and if a immigration authority wanted to access that, they would have to have a warrant because it's in your notes. So it's protected by HIPAA, just like other things that might be mentioned in a mental health session or a medical visit. So kind of good tenets to keep in mind is focusing on educating and communicating. So some ways to do this, some clinics will have posters or flyers in native languages in their offices so that people are educated about, okay, what are their rights, that they can talk about their immigration status with their provider. And healthcare providers, authorities do not equal immigration authorities, so that they feel encouraged to receive healthcare for themselves and their children. So another good thing to keep in mind is thinking about in your clinic, are people being asked about their social security number unnecessarily? That might make people feel unwelcome or on edge and less likely to engage in or receive healthcare. And it's great to use community workers, so people from these communities who have had similar experiences to educate. Reach out to the community, let them know these are safe places where the focus is on their health, their healing, rather than, the immigration legal process. And so good to, again, clarify the confidentiality of health information. So all that said, kind of got to take it on a case-by-case basis, right? Because as we talked about, maybe this fear of deportation or their immigration journey is significantly affecting their mental health. So, it would kind of assess who the client is, if it's relevant to the care that you are giving them. But it might be something that you do need to talk about and fairly explicitly with the patient, but again, within this patient-provider confidential relationship. Other good tips for working with this population, again, at a more systems level, is establishing clinics in areas where these populations are already located. Also can be good to reach out through churches or mosques or community centers to, again, make things more accessible to people than having to kind of navigate, okay, gosh, where am I going to find this clinic that has this provider, et cetera. Having clinics in the community seems to improve community relationships with local providers, stakeholders, and families, and improves trust and visibility of mental health services. And we have some of these in New Mexico. So in Albuquerque, we have the Southeast Heights Clinic, which is located in an area where many refugees end up resettling and living. I mentioned the Department of Health program that works with refugees. And then we would also think about, kind of along the southern border in Las Cruces, these might be areas where it'd be good to have care accessible. Of course, we're in the age of Zoom as well. And so I don't know, that'd be interesting to explore, like, what data is there about making telehealth more accessible to these communities, but would be something worthwhile exploring. And then finally, when we're kind of thinking about developing community programming, it's critical to work alongside the community rather than on behalf of the community. So we don't want to be a voice for the voiceless. We want to pass the mic, amplify the voices of the people who do know what's best for them, and that's the community itself. So very important to listen to community leaders, as well as people on the margins of communities, to hear what do people want, what's desired, what do they feel like would make a difference in the mental health or the physical health of the population. And I think just, for any of us doing work in healthcare, mental health care especially, or work with any marginalized group, it's important to ask ourselves, why are we doing this work? And the quote on the right is a great prompt about this. Is there a possibility we're getting some personal gain from this work by centering this narrative about ourselves as helpers or even saviors? But rather, I hope we can, identify ways that the work is enriching, enlivening, life-giving for us, ways that immigrant families enrich our communities, and thinking about the ways this work benefits us personally, because then we can approach it from a more authentic standpoint rather than this kind of hierarchical narrative that could perpetuate these systems that these populations are already really sensitive to being oppressed or marginalized by. So just a couple kind of good quotes here to end on. And I think, something to think about when I mentioned in my bio, many of us come from families who made similar decisions. Probably all of us did at some point within human history. And so it can feel like this work of reaching back and providing the welcoming home that maybe our ancestors needed at one point or another, reaching back to welcome those who made, this brave choice to step across a border. So here are my references. And we'll be interested if you all have any questions or thoughts for me. Otherwise, I have some questions for you about maybe ways that you've had your practice change to accommodate immigrant families, patient stories maybe that you've heard that have stuck with you, that changed your mind about something, that highlighted a need, or thoughts that are percolating for you about ways that you could change your practice to be more supportive or accommodating of immigrant families. Any thoughts? I don't know if people have worked with this community very much. I see Dr. Shed unmuted, so I'll pounce on that.
I have a quick question. So I'm thinking about this from a forensic point of view. One of the things I noticed, you were mentioning sort of, even if it's a short period of time versus a longer period of time, there's still some dysregulation and some behavioral, some things that are popping up for people. And I know most of this research is relatively recent, but we know that one of the risk factors for future offending is caregiver separation early and some of these dysregulation factors. So have you thought at all sort of about, it's hard to project out because this is sort of coming on the radar more recently, but some of the things that you might be worried about in the future in terms of, like, we've seen some of the short-term effects, but are there long-term effects that we might expect? And how do we sort of mitigate some of those early?
Yeah. Oh, so that's interesting you mentioned with the forensic perspective. So I do forensic evaluations of these populations. So it documents, their psychological state for use in their cases. And so one of I kind of have at the end of the evaluations, I'll have these paragraphs that if it's relevant to each client, I'll include. And one of them is about family separation as an adverse childhood experience. So, we don't know a whole lot about like you said, this is all kind of in the last few years, so we don't really know what the long-term effects are. But we do know about ACEs, adverse childhood experiences in general. And we know that the more ACEs a person has, the higher at risk they are for not only mental health problems, right, like depression, substance misuse, just a decreased quality of life overall, but also medical problems like hypertension, heart disease, even dental problems is one of the things listed on there. So I think it's concerning, especially because if we think, oh gosh, now this is a population who maybe went through this family separation and now they're stateside, and I can't imagine being a parent going through that and then thinking like, oh, and then I'm just going to go to, a U.S. hospital to get care for my child. Like whatever they have going on, I'm probably just going to try to treat it at home, because how terrifying. I don't want that to happen again. So I think it's a fairly high risk population. And that's where I'm hoping that, community that as providers, one, we can reach out to these communities to see like, how do we liaison with this population and provide support. I think pediatricians will be kind of at the front lines of trying to do that, because people might be more likely to get medical care than psychiatric care. But I think it's going to be a problem that we're reckoning with for, decades.
Thank you. And the first thing I should have said was that was a great presentation.
Right.
And I have some thoughts about, I'm always looking for ways to collaborate. And one of the things that I was just thinking of is we are sort of forcibly putting people at higher risk categories for certain things now because of the way that these policies, because of the way things are happening at the detention centers. So I'd definitely be interested in some collaboration about thinking about those future things and what we know about research in terms of, like the forced family separation, just a very, and the ACEs are a very salient risk factor. So not only thinking about, okay, like the optics of this look really bad, but hey, what's going to pop up in 20 years?
Yes, right.
I think people think about public safety a lot. So I would be very interested in collaborating on some of that stuff.
Yeah, absolutely. And that's something that I'll talk about in these evals as well, is that, ACEs also put people for being at risk of criminal behavior and things. And like I said, with the refugees who, are maybe born or grow up largely in a country outside of their home country, there's just this like, what is their personal relationship with the state that they're growing up amongst? If their first memory of the United States was being taken from their mother's arms, and then these people are going to stay in the United States and become Americans. Yeah, it seems like there's a lot to explore there, and hopefully like some good harm reduction that could be done. So yeah, that would be interesting to think about. I don't know if other people have thoughts on kind of that question about potential long-term effects of family separation or interventions that we can start to kind of think about to mitigate some of the risk.
I have a question. And this is a little bit of the partnership that's been already brought up. We have a unique program that we're specifically supporting asylum seekers and accompanied minors and refugees up in northern New Mexico. Oftentimes collaboration is a challenge up north. We come to find that services are always centralized in the Albuquerque area, Las Cruces, south of New Mexico, but up north, we have families that are relocating from Central America that have been on the MPP program for a number of, for 2 years. We have unaccompanied minors, and we have those families that have been here for generations, and they are seeing that long-term effect of those social issues such as domestic violence, substance abuse, and family separation, involvement with CYFD, and these different systems of like court, law enforcement, and limited resources. Are always an issue here in northern New Mexico. So how can we create like a funnel, a relationship per se, that way we can make that better and create more awareness around these issues, because we live in some remote areas where resources are extremely limited, particularly now with families losing jobs because of the pandemic. I mean, this is another root cause of mental health, stress, and anxiety as well.
Absolutely. Jose, will you tell me, what's the organization that you work with in northern New Mexico?
Las Cumbres Community Services.
I'm just going to put that in the chat. And when you say it's really hard to access resources, is it like mental health or healthcare providers, or just like social resources?
I think housing? Social resources does turn to be an issue sometimes. Social resources, financial assistance, that is one thing that oftentimes we come across as an ongoing issue with families, and we have to dig under rocks, under different ways to access these resources for families, and it's really an issue.
Right. I wonder a couple thoughts. I mean, one, you know, it would be interesting, you know, with University of New Mexico, if there's any kind of partnership that could come up. I know we have our Community Behavioral Health, CBH, is a program that is really interested in rural care and developing programming. But I also wonder, just like talking to the population you serve, what kind of folks are saying about what they need or about you know, thoughts that they have about like acquiring those resources, what like the highest priorities are. But I'd be very glad if you have my email on here, kind of anyone with other questions or thoughts or potential collaborations. This is a population I'm really passionate about serving and trying to understand and help the best I can. I'd be glad to like talk with you and potentially connect you with folks with University of New Mexico. I don't know if other folks have thoughts about that, but that's really difficult, even in urban, like fairly resourced areas. These are hard questions. Yeah, I don't know if other folks have thoughts.
I think you mentioning CBH is a great resource because we do have a big focus on reaching out to rural communities. And CBH's name might have changed over time because I think originally there might have been a rural component to things, but I've gotten here since after that change, so I don't want to say for sure, but I do know that we have significant trauma interests at CBH, and there's quite a few people who are doing trauma work and work with refugee and asylum populations. So there's definitely room for collaboration. And Dr. Canaca, who is he was supervising, who was giving some input, I think, for this presentation, maybe, also does a lot of like rural reach out, which has been less during COVID. But I think we were just talking in faculty meeting about it ramping back up. So I think it's a rich environment to try to foster some collaboration.
Terrific.
Do you have time for one more question?
Yeah, I think so.
Yeah, so I wonder, you know, the federal policy is really, well, I guess the rhetoric around it is quite contentious. And it seems like there's kind of this bipartisan support for detention, which is creating all these problems, separation. Do you have any updates with this shift in administration about where the policy is going? And just your thoughts about the most humane policy?
So I think, so the latest, my understanding is, this is like always changing, is that it was announced that there would be no more families detained as units. There were 3 detention centers. It was in Louisiana, one at Dilley, Texas was one. There were a few where families were detained as groups. And so those are closing, which on one hand, like sounds really great. Like, yeah, no more kids being detained. But it makes me worried, and I know there's other advocates that we're not exactly sure what that means though. Like, so are you going to keep the adults detained and then the children will be separated and let into the community, either to live with family members or the Office of Refugee Resettlement? Even though they do refugees, they're the ones in charge of working with unaccompanied minors, actually. So they have some housing facilities for unaccompanied minors. I don't know if like these kids who came with their families would then be considered unaccompanied and fall under their jurisdiction, or if they'd be with foster families or what. So that's a little concerning to me. I think it's a good step, but then it's like, okay, so then where are these people going to be? So I think that's a step in the right direction. But we do know that likely when people first arrive, there is family detention. And so another thing that's been going on for the last like 9 months or so during the pandemic is that there's something called the Flores settlement. And this has to do with how long immigrant children can be kept in detention. And they have to be kept in what are called safe and sanitary conditions. And so once the pandemic hit, a federal judge ruled that these conditions, as you kind of saw in the pictures, were not safe nor sanitary. And so children had to be released within, I can't remember the time frame, it was like 30 days. And so you might think, great, these kids are going to be released from detention, which is not an optimal environment for children. But the adults were not, their parents were not being released with them. So that's something that's been going on in like the last few months, where advocates have been trying to say the most humane thing is to let the families out together rather than separate children from their parents. Good that, again, a child isn't in detention, because we saw that graph has a lot of adverse outcomes, it seems like. But also we know children do best when they're with loving, capable caregivers. And some of the interesting information about detention as well is that parents, after they have been detained, rate their level, a significant number no longer think they have the ability to properly parent, when before detention they had no problem thinking that they were adequate parents. So in this article that Dr. Sidhu and I wrote, that'll be out in JCAP in a couple of months, we give policy and clinical recommendations, and policy recommendations include that families should not be separated, that the beneficence, I can never say that word properly, but the good outcomes, or I guess like goodness of the family unit, should always be kept at the center of policy decisions. And if there is a situation where a child needs to be separated from their parent, the benefit of that child needs to be like the center of those family court decisions, and they do need to be done in those sorts of realms. So I don't know if that totally answered the question, but it's an ongoing policy, and I don't think, kind of connecting back to Dr. Fairfax-Colombo's question, like we're not in an optimal place where we're welcoming these children in a way that's going to set them up to be like the best neighbors and fellow Americans that we can. Not yet. Great. I know we're kind of at about the end of our time. Anyone have final thoughts or anything? Like I said, here's my email, so feel free to reach out if you have kind of follow-up thoughts or information I should know, be aware of. But otherwise, thank you all so much for coming and agreeing to chat about all of this today. Very glad you were able to make it. And yes, Anthony has put up the, here, I'll put this up as well. Here's the evaluation link and code, and Anthony is putting in the chat as well some more information about that. Great.
Hey, thank you, everyone. Thank you, Olivia, for the wonderful presentation. Excuse me. So I have posted the link in the chat, everyone. Please feel free to click on it if you're requesting CEs. It's your responsibility to save your copy. The certificate will be automatically generated, so you can save your copy by screenshot or by printing your page or by re-entering your email. I'm going to go ahead and stay on for an additional 5 minutes in case anyone has any questions if they're having trouble accessing it. Otherwise, you are all free to go. Have a wonderful rest of your day. And thank you once again, Olivia and Megan, for the presentation. And I look forward to many more.
Thank you all. Have a good day.
All right, folks, I'm going to set a timer for 2 minutes. Until then, after the 2 minutes, I'm going to end the webinar.